Very good evening, my beloved colleagues throughout the world. And we welcome you to our today's topic. And you already know about, and this is myself, Dr. M. Osman Ghani here to discuss today's topic. And very grateful to all of you that you are all now in time. And it will be easier to start in the right time now. And this is our institute, some of you know. If we go to the topic of today, the common lab test in general practice. Many things could be known and to be understood, but the common thing as a practitioner, like you, myself, what I am facing, and I am thinking that these will be the common, and we have selected those topics in this today's limited time. So first of all, we need to know about the point of care, a little just worldwide concept developed to do some simple tests, especially those who are GP beside their chamber. And just see, doctor, that what the point of care testing means. Will some analysis be done where the healthcare is provided close to or near their patient? That means you are seeing the patient beside your chamber, there will be opportunity. And you understand that usually it can be done by the DB stick test. Okay. And, actually, you don't need to know details. This is the concept I just share as we are talking about the common test. And as by the door side test may have some limitations also. Maybe adequate health manpower may not be available there. Anyway, so now come to the common investigation, and today our topic will be mainly on the complete blood count. Another name is the full blood count. Some kidney test is a little general practice or family medicine oriented word actually I am using here. And scientifically, you will tell that renal function test, liver function test, but in my choosing word that I gathered in the last many days observation, as we need to talk to the patient well, for that I have selected intentionally such word, the complete blood count or the blood test may be common blood test, kidney test, liver test, the test for the diabetes. These are very common, we must know. Thyroid disorder and a little miscellaneous issue. And we like to start with a complete blood count report now, but my humble request to all of you, doctor, today's session will be actually of interactive mode to learn more. And if anybody can interact with me, I believe that you will be the best benefited today. It will not be a traditional lecture one way I'm telling and you are just listening. You will be detached or attached, whatever. But those who are more attached and you have enough time to be with me, be connected and be interactive with me, doctor. And whenever you need to ask a question, you can unmute by yourself. Sometimes you need to raise the hand. Raising hand is better to conduct, doctor. So now come to there. Before going to a complete blood count, just interesting observation, doctor, you can see here that how a complete blood count result or full blood count result can be erroneous for some technical reasons, rather to say. Nowadays, you can find easily the platelet count low because we are now attending the platelet count for the dengue patient throughout the not world, I am saying some endemic zone in the world now, especially South Asian people, South Asian countries. And this is due to the clot. By nature, platelet have tendency to clot. So count will be low. Similarly, the patient actually will show increased hemoglobin wrongly if patient have these features or underlying these other problems. These are not uncommon, doctor. You see the lipemia, jaundice, a very common problem. And having a very high WBC count in the leukemia or somewhere. In that case, though patient hemoglobin may not be truly high enough, but the analyzer will show increased hemoglobin. So such information I just share, you will read by yourself later, doctor. You can make a snapshot also and available in the book as well. So these are the actually called the spurious results. That means the erroneous results. False result can happen. Now, a common understanding when we go to analyze our complete blood count or a peripheral blood film study, in the process of erythropoiesis, you know that when RBC become mature, the size will becoming smaller and become a normal size. So in the vitamin deficiency, the maturation failure is there. So size will not be normal, will not be smaller as usual. Here you see the iron problem, if there, then RBC size become more small than usual. Then we say microcytosis, and the vitamin deficiency, we say macrocytosis. In the macrocytosis, there are two groups: macrocytosis with megaloblastosis, macrocytosis without megaloblastosis. So megaloblastosis can happen actually in the bone marrow problem, deficiency of the B12 folate. There's some other condition, doctor, you see that elevated plasma lipid, liver disease, hypothyroidism, alcoholism, hyperlipidemia, pregnancy also can cause macrocytosis. In summary, doctor, just to say that all macrocytosis are not megaloblastic. Usually common causes to ours is B12 deficiency and the folate deficiency. It is due to the defect in the production of the RBC in the bone marrow. So these are also common diseases. You see hypothyroidism, liver disease, alcoholism, pregnancy, these are common diseases. Whenever we find any CBC report with the MCV high, we can think that it is just an association, not giving additional information of blood disorders. But if we find the megaloblastic issue, that means to confirm the folate and the B12 deficiency, we can check the blood level of that biochemical test. And to exclude myelodysplasia, we have to go to the bone marrow study. And if the history of the cytotoxic drugs is there, then we can think that maybe due to the drug effect. So with this basic information, doctor, I'm now showing one complete blood count report to you. So in the exam purpose, though it is said as the OSCE, and I'm not giving data like a questionnaire. I will give you a patient brief later in some examples. But here you can find a blood report, how to start with. Dr. Abdullah, are you connected here? Or Dr. Abdullah, please, may I request you to be connected, doctor? Just to interact with me, Dr. Abdullah.
Yes, doctor.
Yeah. Doctor, if you start to see a blood report or any investigation report, from where you will start to see? Usually?
Hemoglobin first.
Hemoglobin, okay, then you come down the report.
Yes, I will check also.
Okay, good. Does anybody have any idea to start, to look at the report, how to start with?
GBC.
What one, doctor?
GBC.
No, I'm telling that like a report shown to you or your patient brought a report with you, with the patient. You will look at the hemoglobin. Okay, the findings will be there. But thing will be, we need to see at the date of the test, age of the patient and the name of the patient. There might be some mistake, doctor. Dr. Abdullah, you understand my point?
Oh, yes.
Identification is number one. And we usually, sometimes we ignore it and we fall ourselves into problem. So now look at everyone. The name, Mr. Bashar, right? Age is 45 years. There are some referring doctor and other not much important. Name, age, and the date could be there. May not. Actually, date was there. I just snipped out for making the slide better. So this gender and you see some reports are there accordingly, the hemoglobin according to the gender and the age. So it is very important to know about that. Now come down. I am asking all of you, anybody raise the hand to tell me what bad observations you are getting here. Anyone please, by raising the hand, just look at few seconds and tell me. Please try, anyone, please. Yeah, Dr. Yasmin. What observation? Important observation.
Pancytopenia. This patient has pancytopenia.
You are telling the findings, right? By pancytopenia. Can you focus, doctor, your finding why you are telling this is pancytopenia?
WBC, hemoglobin and platelet all are low.
WBC also low, doctor? Sorry, doctor, you may have some noise surrounding. WBC low, doctor. Anyone can counter, doctor. Is WBC low? Who will say? Is WBC low?
No, no. Yes.
Now you realized.
Yes.
So, doctor, don't mind just how we do our mistake in our chamber, even during our the evaluation of the patient's report. So we need to be attentive. So we find that some observation here as such. And anyway, I'm going back first. The hemoglobin is low, platelet relatively little low, lower than the normal range. WBC relatively high. Now you don't know the symptom of the patient. Anyway, for exam purpose, I am telling. But if you are the doctor of the patient, you know the symptom and some signs. But by looking at this report, what will be the next investigation we need to advise? We said that this is a bicytopenia with leukocytosis, and too much high leukocytosis. Maybe underlying disease we are thinking about. What could be underlying diagnosis? Just probably, and we will see the next investigation of this. Can anyone, Dr. Abdullah again? What disease we are thinking? What disease we are thinking?
About like leukemia,
Leukemia. So if it is the leukemia more likely, what investigation we will advise now?
Bone marrow testing.
Actually, we need to go for the peripheral blood film first.
Okay.
Usually, bone marrow will be there, but peripheral blood film can give us a more clear picture of the status of the blood in the peripheral circulation. So what we expect there in the peripheral blood, you know that these are the findings actually, doctor, I have shown to you important observation, including atypical cell, 50% here. So more likely could be leukemia. Leukemia, though red cell distribution wide is mentioned here. I will tell you later a little more about this RDW. But up to this, it is a bicytopenia with huge leukocytosis with atypical cells. What may be the atypical cells here? Maybe the blast and others. So without, Dr. Abdullah, without looking at the peripheral blood film, we cannot say that these are blast cell or some premature cell. Okay. So if it is the peripheral blood film now, what is the feature given to you? Dr. Abdullah, can you see it down and give me opinion or observation? Microcytic, hypochromic with few nucleated RBCs, markedly increased shift to the left. What is the meaning of shift to the left, Dr. Abdullah?
Marked increased shift to the left. To the left.
Left means immature cells are more. Immature cells are more. And the myelocytes are present along with metamyelocytes, band form, and mature neutrophil. So some mature neutrophils are there, but some immature cells are there. So it's a leukemic process. Okay? Leukemic process. Platelets are mature, no problem, but distribution little less. And probable diagnosis is chronic myelocytic leukemia. Probable diagnosis rather. Okay? And to confirm the diagnosis, now what will be the next test?
Bone marrow.
Bone marrow. Very, very right. Very, very right. Thank you very much. And now a little information about the red cell distribution wide. And nowadays, the complete blood count report or full blood count report includes this observation. And in the very few of us know about this more really, and we are learning more and more. And how it helps. how it happens. But the term indicates this is the difference in the size and shape of the RBC. Suppose in iron deficiency anemia, just to make a simpler understanding, the variations of the size, you know the word of the anisocytosis and poikilocytosis. The variations in the size and shape. If more anisocytosis and poikilocytosis, these are more in favor of iron deficiency anemia. Usually, in the iron deficiency anemia, you see the RDW will be high. But in the thalassemia, there may be again differentiation. But usually in the heterozygous thalassemia, RDW is normal. But the homozygous thalassemia, RDW will be elevated. Just a little touch, doctor, I just shared with you, as we need to face such report in the complete blood count. You can go through by yourself, doctor. If you don't have the information, I request you, you can make a snapshot also. Similarly, you can find a word in the complete blood count, PDW. That means platelet distribution wide. It means actually the difference in, again, the morphology of the platelet. Morphology means, you know, the size, shape, and others. And it is found that wherever the morphology is more variable of platelet, then it will be more active. So RDW more means platelet activity is more. And doctor, you can remember, in some diseases we find platelet count is low, but clotting disease is there. You can remember. Platelet count is low, but clotting behavior, clotting tendency also in the patient. It can say that maybe in this patient, PDW will be more. That actually, I got my message in the last few years, doctor. It is very latest addition in our complete blood count analysis. Okay, with this few words, doctor, going to the next one again. Quiz to you. Anyone, please raise the hand to tell me what a gross observation you find here in this complete blood count. Again, it is a 65-year-old patient, female patient. Please have a look and raise your hand. Or anybody can be unmuted also. His mic is with your control. Can anybody say, please? Don't be very serious. Just look at the gross findings where actually we look at mainly, we look at the 3 cell count. Then if it is ESR added here in some report, you may not get ESR. ESR will be given in a separate report. But the report I collected here, there is ESR. And there are some, if you found that hemoglobin is low, immediately we have to look at the MCV, mainly MCV. In addition, we can look at the MCH, mean corpuscular hemoglobin. So now give your answer, doctor, which is gross finding abnormal here. Nobody getting anything. It's not abnormal, doctor, 100.05. So if I ask you anyone, doctor, please, can you tell me in a patient 65 years old, if ESR is more than 100, what may be possible underlying diagnosis? Possibility. There are some diseases where ESR will be too much high. Can anybody say anyone?
Rheumatoid arthritis.
Could be if there is very, very severe inflammation. Any other disease?
TB.
Tuberculosis, right? Even long-lasting tuberculosis can produce these high ESR. Any other? Malignancies, advanced malignancies there.
Temporal arthritis.
Could be there. Could be
Temporal
there. Again,
arthritis.
yes, and the multiple myeloma. Multiple myeloma. So these are few diseases where the ESR could be high. So as a doctor, I will evaluate my patient with this ESR. But one very important tricks, doctor, I like to share for the ESR. What will be the normal ESR of 65-year-old female here, upper limit of normal? Can anybody say? There is a trick by looking at the age, not looking at the range given in the report. Can anybody say? No problem if you cannot say.
30-35.
How can you say, doctor? Can you explain? Please. Yeah, Dr. Tarfa, can you explain? Who is answering maybe? Anyway, so we need to divide the age by 2. So what will be the result here? Someone be connected, please. Result will be 34. Sorry, no. 32.5. Whatever, it may be suppose 32. For the female, we will add 10. So it will be the 42. ESR will be 42 upper limit. This is a very standard calculation you can follow in for your any patient doctor. If it is the male, then we need to add 5. That means age divided by 2 plus 5 is the male ESR upper limit, and age divided by 2 plus 10 is the upper limit of the female ESR. Okay, so it is very simple and not much enough information is here. Now showing to another report now. Please look at and try to identify. Doctor, may I request you, if you have any pen and the paper, you can just write down in the paper. It will be easier for better understanding, doctor. If you have opportunity, you just write down in a shorthand in a paper your observation. I will show you the next slide. Quickly look at, doctor, and better not to give 1 minute time, because in your chamber you are looking the report and you are looking the patient. So what could be abnormal findings? Please, anyone can raise the hand so that we can proceed further, doctor. Please proceed. Raise the hand, anyone to say? And you can raise the hand, look at and tell also, doctor. No need to be confident earlier. Very easily we can find that hemoglobin is low here, and try to identify other findings.
This is pancytopenia.
Yeah, pancytopenia now. Okay, pancytopenia. And what about the morphology of RBC here? Just a gaze only. What is the morphology of RBC, doctor, here? Maybe Dr. Yasmin was talking.
Macrocytic.
Micro. MCB is 105. So macro, big, right? Bigs are there. Bigs are there. So if it is a too much big macrocyte, what may be underlying disease? Doctor?
Megaloblastic anemia and folic acid deficiency.
Could be. Very right. Could be. So now what will be the next investigation usually? If we suspect this is megaloblastic anemia due to vitamin deficiency.
Serum vitamin B12.
Very right. Serum vitamin B12. But don't jump to the bone marrow study. If we find this MCB high, I'm sorry I couldn't mark it here, then more likely could be folate or vitamin B12 deficiencies. And check the blood if available. Then you can get the diagnosis and treat the patient accordingly. Again, you are the doctor for the patient. By clinical history and examination, you can proceed further. So bone marrow will be an invasive procedure. But if MCB is not giving that much high, maybe normal or low, but we got pancytopenia, then usually we need the next investigation will be the bone marrow study. Okay, but it is safe. Suppose you have found that vitamin B12 and the folates are interestingly normal somehow. It is not absolute that the 105 means mandatorily it is a vitamin deficiency, but more likely though, if you don't find it, and we are going further evaluation, it could be a peripheral blood film usually. Always, doctor, before jumping the bone marrow study or even the vitamin test also, whenever we find any cell deficiency, suppose RBC deficiency, WBC deficiency, or platelet deficiency, we need to go for peripheral blood film because it's very easy. Very easily we can get it for that. And you got the microcytic hypochromia. Microcytic, I'm sorry, doctor, it is not micro. There is some error is there. The report was done a little confusingly. You see, MCB is high. It is not microcytic, doctor. Sorry. I need to correct it later, doctor. We are discussing about macrocytosis. Whatever, if as such the report, I'm just showing you now, doctor, the next one. So if the pancytopenia, usually we will jump to bone marrow histology. It's my intention to show you the bone marrow here. For that, I just jumped a little. Now, you can see how bone marrow looks like. Most of the area of the bone marrow occupied by the fat. By the fat. So this is the normal appearance. And why I'm showing many of us, possibly, I am not telling everybody. We discussed about the bone marrow study and other. We have gone through the report. Possibly we did not see the appearance of the normal bone marrow in the picture. Maybe, I'm sorry to say, those who have seen already for you. So we need to understand, we need to recapitulate by looking at the picture. This is my idea. So this is the bone marrow normal, the white areas are the fat. And if you come to look at such bone marrow of our pancytopenia patient, yes, doctor, please. Can anybody comment here? What is the observation in the bone marrow by looking at the picture?
More white fatty cells.
Fats are more. It means the cellular proliferation is less. So what could be the more likely diagnosis?
Pernicious anemia.
Pernicious anemia. Pernicious means you are thinking this underlying vitamin B12 deficiency, and vitamin B12 deficiency causing such thing. That means the less proliferation of cell in the bone marrow. Okay. Ignore the vitamin deficiency. We discussed that the vitamins are normal. Vitamins are normal in the blood. So it is not vitamin deficiency. What could be other than this?
Aplastic anemia.
Very, very right, doctor. Very, very right. Very, very right. This is aplastic anemia. That was my target, doctor. I'm sorry. Unfortunately, the slide preparation was a little confusion there. Macro or micro. But it is also true. It is also true, which seems to be macro in the MCV, maybe confusingly, maybe error somehow there. But the hematologist who has seen the slide, he identified the peripheral blood as microcytosis. Just I am in favor of the doctor only, doctor. So in this case, vitamin deficiency actually not be there. And now as a pancytopenia, our usual target by investigating the bone marrow to reach a diagnosis. So this is the appearance of aplastic anemia. Now, as a doctor, we will identify what is the cause of the aplastic anemia. Drug may be a very important cause. Can anybody say one important drug which can cause aplastic anemia?
Methotrexate.
Very right. That means all the cytotoxic, most of the cytotoxic drug, rather to say, cytotoxic drug. But it is also true that vitamin B12 deficiency causes pancytopenia because they are giving the faulty development of the cells in the bone marrow, not this much aplasia. Maturation failure of the all line of the cell by the B12 deficiency. These also cause pancytopenia. Okay, thinking up to this, now we are coming to a patient that may I request Dr. Abdullah Akhir, please can you read it for us?
Yes, sir. A 34-year-old Asian lady presented with tiredness and lethargy. Otherwise, she is well. On examination, she is mildly anemic. What is your initial investigation?
Yes, so Dr. Akhir also can answer, anybody can answer. Suppose this is the patient, this is the core symptom. Otherwise, she is well, only tiredness and lethargy. That means patient does not have fever, does not have any bleeding, only tiredness and lethargy. A 34-year-old, and interestingly, she is your neighbor, Asian.
Sir, complete blood count, CBC.
Complete blood count. Any other test initially, including a peripheral blood film?
Peripheral blood film. Yes, sir.
What you are thinking about the cause of the tiredness in the hematologic point of view?
Sir, yeah. Iron deficiency anemia.
Rather to say anemic, already you see mild anemic in the examination we found. Yes, so the tiredness, lethargy is due to the anemia. Whenever we get anemia, we must include a peripheral blood film. Okay? Yes. We must include the peripheral blood film. So in the CBC and the peripheral blood film, suppose in the minimum in the CBC report, auto-analyzer report, we can focus on the 3 cell line and the MCV here. So MCV is low. So more likely, Dr. Akhir was saying it might be microcytic hypochromic anemia.
Sir, microcytic hypochromic anemia.
In the Asian lady, what may be the reason of microcytic hypochromic anemia?
Nutritional.
Nutritional. Thalassemia.
Nutritional area.
Inadequate iron intake.
That means nutritional. Iron
Yes.
intake also low, vitamin also low. Actually, if we consider the intake problem is for the iron or the vitamin?
Both.
Both. Just to compare, intake problem is vitamin. Loss problem is for iron, doctor. Yeah? I think all
Could
of
be
you understand.
malabsorption.
Yes, malabsorption is the intake problem. Iron malabsorption. I am asking about that. Usually, the intake issue is relevant with the vitamins. Iron also a nutritional, whatever we say. But if iron and vitamin problem is there, it will be a combined problem. And at that time, what will be the appearance of the mean corpuscular volume? Can anyone say? A little tricky, rather to say an advanced discussion. Who attended before the discussion? Anybody can say.
Maybe thalassemia.
Might be normal.
No.
Maybe normal. Normal.
Yes.
Maybe.
Maybe normal. So how can we now clarify this abnormal? There may be, suppose auto analyzer cannot say you MCB in different values, right? Suppose auto analyzer detecting the small cell now, so machine is giving this, but there are in between big cell. So auto analyzer is not giving you two report of MCB. So sometime for that I told you auto analyzer MCB may be confusing. For that, we need to go to the peripheral blood film study. What I discussed about, including iron deficiency and the vitamin deficiency. If there is a maturation failure, iron deficiency will be also there. Actually, the cell size will not be normal or smaller. So iron deficiency may be hidden there. Vitamin deficiency may be evident there by increased mean corpuscular volume. Increased mean corpuscular volume. But whenever we find a small cell, invariably, if you compare vitamin and the iron, invariably it will be the iron deficiency. Dr. Abdullah, do you understand? I'm actually asking all of you. Whenever we find mean corpuscular volume is low, we can say that there is iron deficiency without vitamin deficiency.
Yes, sir.
If vitamin deficiency also will be there is a tendency to show the MCB high, though there is iron deficiency. That is a complex or the mixed picture. Anyway, thing will be clear to you maybe later. So up to this, our initial investigation showing that is a microcytic hypochromic anemia. Dr. Abdullah was with us. Now, what are the differential diagnoses we can think of for microcytic hypochromic? Actually, we cannot say hypochromia, maybe hemoglobin low, for that we are telling hypochromia. The MCH, we actually not shown. Even then, wherever the microcytosis is, more likely there is hypochromia. So now what are the possible causes?
Iron deficiency.
Very good. Then
Thalassemia.
Thalassemia there.
Sideroblastic anemia.
You are telling from the book. Okay. Any other?
Chronic illness.
Anemia of chronic disease.
Anemia of chronic disease. I think some of you or most of you could not see the
Microcytic anemia.
Sorry, doctor, which one? Anyway, we can consider these 5 diseases are here for this microcytic hypochromic anemia. Actually, doctor, my intention today is to guide you how to proceed further for further evaluation. We are looking in the book, all the investigation available. In the indoor, your consultant advised many investigation. You are looking together. But as a doctor, when I am alone, I am dealing a patient, I need to step up of investigation. So this is the way for that I made the slide in this manner. So now we formulated, suppose 5 common differential for the microcytic hypochromic anemia. Now, what will be the next investigation?
Ferritin.
Doctor?
Ferritin.
Ferritin. To identify the That means to confirm ferritin, to confirm iron deficiency, ferritin. Okay, but for the thalassemia,
Hemoglobin electrophoresis.
hemoglobin electrophoresis. These are actually two common causes, isn't it? Two common causes of microcytic hypochromic anemia. Anemia of the chronic disease, how can we identify? I am not asking about the investigation, whether by looking our patient. Anemia of chronic disease means patient is having another disease. There are the features, symptoms, and signs. So easily we can identify. Suppose rheumatoid arthritis patient. This is anemia of chronic disease. A CKD patient. Patient is of kidney disease, diabetic kidney disease, or other disease. So patient will have anemia of chronic disease. So some anemia of chronic disease can show microcytic hypochromic anemia. So for the disease, actually, we don't need to go for further investigation. For common two disease, we need to go further. If it is the PLAB, now you show, it is shown there. Iron status and the hemoglobin A2 is such. 5.2% means in the electrophoresis, only abnormal finding we found is hemoglobin A2. Now, doctor, choose your answer best from this list. Which one answer? Which one is the answer, doctor? Confirmed diagnosis, or most likely? After getting the evaluation.
Aplastic anemia.
Do you think that the aplastic anemia having without bleeding disorder, that means bleeding manifestation, without fever,
Anemia of chronic disease.
could be anemia of chronic disease, but what other underlying disease? Otherwise, she is well.
Thalassemia trait.
Thalassemia trait.
In
Thalassemia
case of
major
breast
will
trait.
not be otherwise well. Thalassemia major will not be otherwise well. Okay. Why it is minor or trait? Can you explain, doctor? If without explanation, if you give the answer, your understanding will not be completed.
So
Major,
that means that one of the
age of
hemoglobin
the
is
patient.
less.
Age of the patient. Usually, thalassemia major patient will present earlier in the life, and otherwise she will not be well. It is also true. Good. Okay. So, another clue, doctor, I like to say, maybe very interesting. Be careful and follow my discussion. Doctor. Suppose you see the difference of the lower limit of mean corpuscular volume, 80 up to 68. That is how many? 12 difference. That means 12 unit femtoliter, rather to say. So it's a significant difference is here. But from our usual value, hemoglobin lower limit, 11.5 per, if I say the gram per DL. It is a 10.3 gram per DL. If I say, I'm not telling about the per liter, gram per DL. This difference is not too much high. In that sense, we can say that the MCB is relatively more low than the level of deficient hemoglobin. I don't know, do you understand my point or not? Dr. Abdullah, do you understand what I mean?
Yes, sir.
That means anemia is not that much severe where the morphology is severe. That means the microcytosis is more severe in proportion to hemoglobin level. Hemoglobin level. It indicates a hemolytic process. Now, if it is a hemolytic process, common diagnosis will be the thalassemia. Suppose the Asian lady, Asian patient. If the thalassemia, now trait and the homozygote, that is a major or minor. So, age 34, late presentation, otherwise well. So, more likely diagnosis. Clinical diagnosis will be also. Clinical means by getting only CBC peripheral blood film, a thalassemic, and maybe the thalassemia trait. By doing the electrophoresis, our idea is being confirmed as it will be a thalassemia trait patient. So, message is that, doctor, for especially mostly possibly those who are the GP or planning to be a GP in future, whenever we get any anemic patient, even the microcytosis, we should not give iron treatment to the patient. This is the message for them. It may be dangerous for the patient because hemolytic process is an iron loading state. So we need to go up to this investigation to be sure. But if patient telling you an apparent cause of blood loss is there, menstrual ready, menorrhagia is there, maybe the worm infestation or somehow chronic blood loss, by in a poor setup in the rural area, we can start iron deficiency treatment as like. But unexplained tiredness and lethargy, better we need to go up to this investigation. So I think I discussed a lot from the complete blood count, and this is the blood report. This is electrophoresis and hemoglobin electrophoresis. This is a normal report. Hemoglobin A2 2.13 up to 3.5 sometimes said normal. More than 3.5 usually diagnostic for the thalassemia minor. So no need to go for the sleep. Better jump into some data. I will show you now. Actually testing your different domain of the learning. There are 3 domains of learning. For the same thing may be learned in a different way. So 4 features are given to you now. All of you, doctor, look at. I will show you the picture again. Just have a look. This is the normal range, hemoglobin, mean corpuscular volume W. This is the platelet. The main focal, the information in the CBC report. Okay. Then I will give you a patients with some clinical points. You will select which CBC report is best fit with your patient. So this is the patient. May I request now anyone to read Dr. Abdullah, please. Dr. Akhir. Today we got two Abdullah. One Dr. Abdullah, another Abdullah.
A 54-year-old male presents with concern over his drinking and its effect on his work. He confesses to a long history of alcohol abuse.
So patient is alcoholic.
Yes, sir. Alcoholic patient.
So what patient actually has developed other disease due to alcohol?
A liver cirrhosis.
Because he has spider nevi on his chest. Maybe cirrhosis, or we can say the chronic liver disease.
Clearly, yes.
Alcoholic chronic liver disease. So in this setup, there is an alcohol also issue. What could be best stem of investigation report? 1, 2, 3, 4, 5, 6, 7 types given. Intelligently, you need to identify. Please, anyone?
D.
Sir, G.
D maybe.
G.
Someone is saying G, E, F, G. Someone saying
D.
D. Okay. So if look at Dr. Alcohol produces RBC size big or less? Doctor?
Big.
Big, sir. Big.
So we need to select the big size RBC answer here. Which one? 110 or maybe 80 little, right? Is that it? What is the normal level of MCP lower value? 80. Sorry.
80 to 95.
Normal. Sorry. 80 to 95.
Normal.
So 110. Is there any 110 or bigger one? 99?
99.
Could be 99. 90, 99, not 90. So answer may be from 99 and 110. Is it?
Yes, sir.
Okay. So 99 and 110. D or G. Now compare with this thing. Platelet count. Normal.
Yes, chronic liver disease.
Or doctor?
With chronic liver disease could be better test.
You are right, doctor. It is intelligent answer. In the chronic liver disease, platelet count tends to be lower. Now come to the hemoglobin level, 8.5. And in the D, 13.5. Hemoglobin level normal, it is hemoglobin level low. What is expected between these two findings? Patient alcoholic. Is there any reason that the liver disease patient have low hemoglobin?
Upper GI disease could be one reason, but he will show with melena or something like that.
Clinically, actually not mentioned, right? You are right. In total hypertension, there might be bleeding. Could be possible, could be possible, could be possible. Now, what is the best answer here? They have selected this one as spider never doesn't mean portal hypertension. Patient does not have history of melena or other bleeding. So it may be the features, including this. Why this is not 110? Because alcohol produces macrocytosis, but 100 not that much. This is the tricks here. Understand, doctor? Alcohol produces macrocytosis a little high up, but usually more than 105 or above is a vitamin deficiency, B12 deficiency. If I say about the MCV issue only. So more likely, platelet may not be always low, maybe in the normal range also, but hemoglobin is 13.5. This is without portal hypertension and liver disease causing macrocytosis, alcohol. And just immediately before I have shown you, the chronic liver disease can produce macrocytosis, but not megaloblastosis. So these are some tricks, doctor, I am sharing with you now. Going to another patient. Who will read, doctor? Please be curious and interactive. Anyone, please, to read it? Or you like me that I will read all the questions?
A 55-year-old female presents with tiredness and dyspepsia. She has been taking ibuprofen for osteoarthritis.
Ibuprofen, doctor, this is a trade name. This is ibuprofen. You understood, ibuprofen, yes, painkiller.
For osteoarthritis of the right hip.
Okay.
On further questioning, she states that she has recently noted that her stools are darker.
What does it mean? Stool darker means?
Melena.
Could be melena. Now, what investigation report is the best fit with such patient? Give the answer. Yes,
B.
Dr. Farooq. B.
B.
This one, B. Dr. B means Bangladesh. Okay. Any other option? Try to choose, doctor. Otherwise, I can jump to the answer. Nobody's thinking. And the thing is very difficult. Which one? B. Very, very right. Yeah, doctor, can you explain why you have chosen the B? Very shortly, doctor. Can you explain for everybody?
Will have iron deficiency anemia, so hemoglobin will be low, MCV would be low, and WBC and platelets doesn't have any reason to go down.
Yes, very right answer. So it's the iron deficiency anemia. Iron deficiency anemia. Because I told you before also, there is an obvious reason is there. Clinical background is there. So do you think that should I go for iron level and the electrophoresis? What do you think?
No. Endoscopy.
Practically no. But we need to see you said endoscopy for the dyspeptic patient for further evaluation. You are right. For the investigation will be designed by the doctor. Okay. Next one. Yeah, Dr. Farooq, you are very bright voice. Can you read it, doctor, for us? Everybody better to share. Please, can you read the question? S66.
60-year-old female vegan presents with tiredness, confusion, and she has a yellow tinge to her complexion and has a peripheral neuropathy.
So what is the vegan means? You understand, right? Vegetarian. Yeah. What is the common problem of vegetarian, doctor?
B12 folic acid deficiency.
You got the point now. So do you think that this is a patient of?
B12 deficiency.
Now identify the result.
So she will have low hemoglobin and MCV would be macrocytosis and can have all blood count low as well.
So already we discussed the issue very clearly before. So what will be the answer now?
G. Answer is G.
Very straightforward. It will be the G. Pancytopenia with very high MCV. Now you got the point. Usually the vitamin deficiency MCV will be too much high other than other issues. Good. Very good. Thank you, all of you. Now, any other doctor will fill? Dr. Abdullah, Muhammad Elamin Abdullah. Can you read now?
Yes.
Please.
Yes. 52-year-old male present with headaches and tiredness. He is a smoker of 40 cigarettes per day. He is obese and has markedly plethoric complexion.
That means reddish.
Mm.
Face become
Head-
red. Smoker. So what
Smoker,
actually
yes.
happened to him and what may be the answer now?
F.
Obese also.
Obese? Obese,
F.
yes. Then F.
So hemoglobin would be high because he's
Plethoric.
yeah.
WBC blood
COPD
rate
patient.
normal. What may be
So he's
underlying disease,
retaining.
doctor?
He's
Polycythemia
retaining, so
vera.
he's COPD.
COPD, doctor, is a smoker for that you are thinking COPD. Actually, what
He's
complication?
retaining.
What is complication? Polycythemia
Polycythemia.
due to COPD.
F answer.
Polycythemia. Mm. So
F.
hemoglobin will.
F.
That was you selected, right, doctor?
Yes.
Yeah,
F.
good, doctor. I feel better that possibly I could make you understand a little of complete lockdown. Thanking you, my gratitude to you. Very good. So up to this, doctor, I finished this testing of CBC. Now come to a common issue of the CRP and the ESR. I think every day as a doctor, we are advising this thing. I will not detail much, doctor, but to draw your kind attention, in some diseases, ESR will be high, but CRP will not be high. Just look at. Usually, these are, you see, SLE, Sjogren's syndrome, that means the connective tissue disease, and the multiple myeloma. So, multiple myeloma is not an infectious disease, it's the blood neoplastic disorder or the plasma cells. So, invariably, there is ESR high, but CRP will be the normal. And the pregnancy and other issues, you see, and stage renal disease, ESR will be high, but CRP will be normal. It can help, especially in the diagnosis of SLE. ESR will be high, CRP will be normal. So otherwise, you can see the slide, doctor, in your book. Thanking you. So I think we can jump now. Anybody have any important question also? You can raise the hand by ask. You can ask the question for a short while. Yeah, Dr. Abdullah may be having a question, please.
Yes, doctor, my question, any blood loss, it will be considered like iron deficiency anemia?
Usually, usually chronic blood loss. Chronic blood loss is the reason for the iron deficiency.
It's like if there is bleeding peptic ulcer.
Yes, iron deficiency.
And external blood loss also? Whatever
blood loss is, if it is the chronic, it is iron deficiency.
Yeah, okay. Thank you.
Yeah. So now come to some other issue. This will not be a detailed, doctor. Especially our intention today to talk about the general practice for that. We've done some common investigation also as well. This is, you see, the myocardial infarction patient. The ECG is changing. The time to time it is proceeding in that manner. A chest pain patient, clinically compatible with the myocardial infarction. So going by days, weeks, and the month in this manner. So today we are not discussing ECG, rather coming down of the lab test down. You can find that usually we are doing nowadays the troponin. More important is the troponin I. If we can make it cardio-selective, it is very good. Cardiac troponin I. Very, very suggestive for the cardiac disease. So the enzyme is going up and down, going up and down. What is the importance of knowing these? Suppose we can do CK also. Initially, it is raised. So initially, troponin also raised. We can choose 2 or even we can choose 1. If we think that, why should we choose 2? Because both are rising in the initial hours. The reason is that some MI patient may have the second attack after 3 days, maybe or 4 days. Initially, troponin was high up to these. So in the 3-day, patient develops severe chest pain again, and it is a second attack of myocardial infarction. By looking the troponin, we cannot identify because it will remain high for even 6 to 7 days. But CK usually in the 3rd day, lower down and low. So if patient develop the MI, second attack, maybe in the 3rd day, 4th day, we may find the CK again high. For that, CK can help us to identify the second attack. For that, sometime we need to go for the 2 tests. Anyway, unfortunate patient may be diagnosed in the very later time, maybe in the 4th day, 5th day. On that day, by the symptomatology, duration of the symptom, we will not go for the AST or the CKMB. Troponin can be helpful. Moreover, LDH could be a good one in this choice. But usually in the GP, doctor general practice, we go for the troponin or CK. Just important message from the slide is that recurrent MI attack be diagnosed by the CK, not by troponin. This is the bottom line here, doctor, okay? And I am showing again the same picture because in the minutes, what will be the change in the ECG was not shown before in the previous slide. In the minute, maybe like that, there may not be a still elevation. May not be still elevation. In the minute, it would be as such. And it is called, sometimes the second picture is called hyperacute myocardial infarction. Hyperacute. That means T is actually above and T going down gradually. Okay. Now come to the lung issue. This is the lung function test. It's very commonly everybody is telling about. This is a spirometry. And these are the some values. We will focus on the forced vital capacity, forced expiratory volume in the first second, and its ratio. In addition, the peak expiratory flow rate more than 80%. These are the normal value. Ratio will be the more than 80% in general. So how to identify the restrictive and the obstructive lung disease? By looking at the spirometry values. Look at doctor. FEV1 and FVC ratio. By looking at, we are thinking if it is a low, okay, if it is a low, usually we may think it is obstructive disease. Is that it? Who can be with me, doctor? Talk. Just to interact with me, anyone? Yeah. Dr. Farooq, yeah, Dr. Muniba Farooq, please, thank you. But if the low ratio we found, we think that this is obstructive, right?
Yes, yeah.
Okay. If it is a high, maybe normal or maybe restrictive, maybe normal also. But for the normal patient, we are not advising the test. So we can think that it may be the restrictive disease. Now, come with me. If it is low, actually, outright, we cannot say this is restrictive disease. Sorry, this is the obstructive disease. We cannot say. There are some in between other talks. So we have to look at the FVC value. It is a ratio only, doctor. It may be normal or maybe low, maybe high, whatever we say. The ratio is low, but FVC may be different, maybe normal. Or FVC, forced vital capacity, may be low also. You see. So if it is FVC is the normal, only FEV1 is less, more likely this is obstruction. But if FVC also low, but ratio is low, it may be the obstructive or the mixed picture. Usually of mixed picture. So absolutely obstruction means forced vital capacity will be normal. Right, doctor?
Yes. Yeah.
Now come to the right. Normal or high, it is found usually in the restrictive disease, but it may be found in the normal person also. So again, look at the FVC, forced vital capacity. Now look at this diagram, doctor. If FVC is low here, more likely this is mixed or obstruction. But here, ratio is high, forced vital capacity is low, more likely this is restriction. What does it mean? Only by looking at the ratio is not enough. Right, Dr. Farooq?
Okay, yeah. Yeah, got it.
So it is a normal and high, is a normal lung mechanism. So is normal high. If FBC is low, at that time only we can say there is a restricted lung disease. I think things are more clear to you now. Thank you. A patient now presented to you. Dr. Muniba, can you read it for us, please, if you don't mind, please? Please.
59-year-old chain smoker complains of breathlessness for 5 months. He has recently been to hospital for spirometry testing, and these are his post-bronchodilator results. So FEV1 to FVC ratio is 0.65, which is low, and FEV1 percentage predicted is 57%. Our colleague gave him short-acting muscarinic antagonist, but he has returned because he has persistent breathlessness. What would be the most appropriate next step?
Okay, no need to read the answer. All of you identify the abnormal finding, especially focus on the spirometry result. So, Dr. Muniba, can you say? The ratio is low. What you are thinking?
So, obstructive, probably. And FEV1 is low too.
This is obstructive disease. Is a COPD patient?
He's smoker as well. Age is going with it. And short acting is not working. So we can say maybe COPD.
So if the COPD as this is not improved, the ratio is not improved. Now we need to modify the treatment, right?
Yeah.
Has given short-acting muscarinic, but not improving, still breathlessness. What will be the next step? What will we do? Just testing your clinical management capability also. Anybody, please, anybody can join.
We can give long-acting beta agonist.
Long-acting beta agonist.
Inhaled corticosteroid.
So this is that very simply obstructive feature. You identify the abnormal. And now the treatment will be inhale steroid, doctor. Someone said Dr. Rasha maybe. Tell me what about steroid? Why you are thinking steroid, doctor? Steroid usually useful in the reversible condition. That means the asthma. Asthma. Yes. We can give steroid in COPD patient for few patients, not all patients. All patients usually given in the case of asthma, not COPD. This is the difference. So answer will be the long-acting beta agonist. But my asking to you, though there is no option, another one. It is called the LAMA, long-acting muscarinic antagonist. LAMA. If we advise LAMA, what will be the caution? Caution is, if we advise LAMA here,
we have to change short-acting to muscarinic to short-acting
LABA. Sorry. Saba, right. Saba. Short-acting protagonist.
Yes, we have to change Sama to Saba.
Yes. Very right. So we need to be cautious about this, right? Very good, Dr. Abdullah. Thank you very much. So with these respirology data, doctor, I am coming to tell you a very important issue of acid-base disorder in a very simple manner. As I learned by myself, doctor, I actually give what I say, it is called what witness or evidence I am giving to you. I understood the acid-base disorder by learning this page I am showing to you now, immediately. Before that, actually, I was in dark of acid-base disorder. Before learning this, look at the normal values as such. These are the normal values. You see the millimole, and then other unit also there. Sorry, this is average, not other value. In an average, some other value by the kilopascal sometime for the pressure it is given. But more we are using the millimeter marker here. Anyway, on an average for easy calculation, I have shown here. Within the bracket is average value. So if you come with an data of a patient given as pH such. So now anyone be with me to answer the question, doctor. Please be connected, anyone? Otherwise, actually, the discussion will not be fruitful. Anyone, please feel free. If I am talking alone, not better. No one, Doctor? Dr. Modi, may I request you? Dr. Modi? We are here connected, we are too busy otherwise. Sorry, doctor. I'm very sorry. If you feel what I say, please, I will be happy. Thank you, doctor. Doctor, yeah. Again, disconnected. Someone connected again, disconnected. Dr. Ala? Very hard for me, doctor, to go on one way. Okay, let me try. If it is acidosis or alkalosis, what will be the answer? Answer will be acidosis because pH is 7.05. 7.05. And now the next question, what is the primary change? Is it metabolic acidosis or respiratory acidosis? Can anybody say now? So really to say by one way, if anybody can interact, it would be better.
Because HCO3...
Yeah, Dr. Abdullah, good. Yeah. Is it metabolic or respiratory? Yeah.
Metabolic.
Why metabolic? And other doctor said respiratory. I will ask you also. Dr. Abdullah, why metabolic?
Because HCO3 is 8. HCO3, 8 millimole.
Metabolic and respiratory depends upon the carbon dioxide and bicarbonate issue. If this change of pH is due to the bicarbonate, it is metabolic. If this change of the pH is due to the carbon dioxide, it is respirology. Now, another doctor who answered the respirology, be connected with me so that I can interact with you. Who are doctor?
Yes, doctor.
Yeah, Dr. Asel, yeah. Okay, this is the acidosis, pH low. So if bicarbonate is low, there may be acidosis, right? Is a lower value. Doctor, you disconnected again. Sorry, doctor. Better be connected. So this change is explained by low bicarbonate here, not carbon dioxide. If carbon dioxide is low, so there will be alkalosis. There will be alkalosis. By looking at the pH, it is not alkalosis. This is acidosis. It means this acidosis is explained by the bicarbonate level here. So answer will be metabolic acidosis. Now the question is, why carbon dioxide is low here? Could it be the added any alkalotic situation? Maybe a question, respiratory alkalotic situation?
This compensatory mechanism.
Usually, initially compensatory mechanism by hyperventilation. So compensatory mechanism by the respiratory system and by hyperventilation, carbon dioxide is going out to pull the pH towards the normal level. So I think this very small brief may be helpful for you, doctor, for understanding acid-base disorder. Yeah, I'm sorry, doctor. Really, I don't feel better if you don't interact. Anyway, some clue given down, you can make a picture, doctor, by yourself. I will not explain the bottom part. Right. Just pancreatic disease. What test we do to diagnose the pancreatic disease? Blood test, pancreatitis. Dr. Rasha? Saram?
Yes.
Which blood test we do for the pancreatic disease, pancreatitis?
What is your question? I couldn't understand.
What blood test, doctor, we do for pancreatic disease diagnosis? Blood test.
Enzyme.
Which enzyme?
Lipase.
Lipase or amylase, doctor?
Amylase.
Amylase will be high, right?
Yeah.
Amylase will be high. But interesting thing is that there are some other disease where amylase will be high. It is not pancreatic disease. Right? It's a relatively not a smaller actually. The list is right. Biliary disease, intestinal infarction, upper GI perforation, all can cause high amylase. So to be confident about the amylase, maybe due to pancreatitis in acute epigastric pain, usual level will be more than 1000. Just to remember that. If serum amylase is more than 1000, more likely due to pancreatitis. Okay. Okay. Now very little thing we are having ahead and we are jumping, doctor. Yeah? The main thing we discussed from the blood test now, we will be going to the kidney test now. And the number one kidney test will be the urine analysis. This is actually your bedside test or the chamber side, beside your chamber. The dipstick urine easily can be done. Those who develop their GP center by itself. So this is a different color matching can tell different results by dipstick. Okay. And I will not detail here more, but some important thing actually I cannot miss also. In the urine analysis, there may be some false positive and some false negative result. Because if the bilirubin test, we actually think there may be false positive result due to the presence of drug phenothiazine. False negative result due to that urine is not fresh. It's a very common mistake. Urine is put delayed, it will give very, very significant bad. I'm telling the bad result means false result. So for the ketone, urobilinogen, blood, even if you come down, the urine glucose, doctor, if you give an example from here, urine glucose also may give false positive and the false negative result, though there is no presence of sugar. You see, false positive sugar may be given in the dipstick urine test by the presence of the peroxide. Chlorine, false negative due to ascorbic acid. False negative means there is a presence of sugar. There is a presence of sugar, but result is negative. So it is called the false negative. False negative. So many examples are there. I hope that you already made the snapshot. You can read it. We need to know about this urine analysis issue. By the macroscopic examination or the cell study, two cells are very important, WBC and the RBC. Usually in South Asian countries, I think all of you know that they will give the result in the high power field. High power field. But it is not the same as cubic millimeter, doctor. Right? It is not same as cubic millimeter. So anyway, in general, I am highlighting you by the high power field in the centrifuge urine. The pus cell usual level will be the 0 to 5. Without symptom, pus cell up to 10 may be normal. Maybe in a borderline situation, but up to 5 is almost normal urine. Normal urine. So pus cell, presence of pus cell doesn't mean UTI. It is also true. Maybe 8 pus cell or 9 pus cell. If there is a symptom of UTI, we can think of it is UTI clinically. And we go for the culture. Okay. And RBC, I've seen the 2 RBC may be abnormal. Now the sterile pyuria, what does it mean? Dr. Ala, can you say what is the meaning of a sterile pyuria? Dr. Rasha is here, please. Sterile pyuria means?
There is no bacteria.
No growth of bacteria in the culture, but pus cell is there. Pus cell is there. If it is a persistent, a little long time, number one diagnosis could be tuberculosis in the urinary tract. Number one. So we need to exclude tuberculosis. Second thing, very tricky, doctor, you see here, you have given the treatment of UTI very successfully, even the culture positive, and you have given antibiotic. But pus cell will be absent in further 2 weeks' time. So if you follow the patient up by the urine analysis later after the antibiotic, if you find that there is a presence of pus cell, it doesn't mean that persistent infection. Clear, Dr. Rasha? Dr. Rasha, please. Can you hear me?
Yeah.
So, yes. After treatment, to say, that means to find the absence of pus cell, we need to wait 2 weeks' time. Not immediately after the treatment. Otherwise, it will be said as a sterile pyuria. So it may be very normal. It may be very normal. So we need to follow the patient up. Incidentally, if you go for the urine analysis immediately after, we can see minimum the less number of pus cells than before. But total absence will be minimum after 2 weeks. That is the thing. So there are some other reasons of the pus. That is the pyuria. So you can go through by yourself, doctor. Sterile pyuria. Now, one important picture I am showing you to identify the urine analysis feature for the albumin, or that means the protein, and the RBC. In the glomerular disease, proteinuria is mandatory. But all glomerular disease does not produce hematuria. If you look at the picture, you can identify. So by looking at the hematuria and the proteinuria, we can comment about the primary disease of the glomerulus. So only proteinuria, without hematuria, this is the left-sided disease. And hematuria and the proteinuria, actually this is the right-sided in the picture, in the left-sided here if I say. So SLE is one kind of disease. SLE can produce only proteinuria. SLE can produce hematuria, proteinuria both together. But few diseases mainly produce hematuria. Suppose, mainly I am not telling, mainly means by comparison I am telling. Suppose in the left side, anti-GBM disease, yeah, good posture, glomerular basement antibody, yeah, anti-GBM. Glomerular basement membrane antibody disease. Here, you see hematuria is very prominent. Proteinuria is less prominent. So whenever we see a report of the urine analysis, we can think of that it may be glomerular disease or may not be glomerular disease. But it is also true that if any damage happen in the urinary tract, anywhere in the bladder or the ureter, they may produce proteinuria, hematuria. What is the mandatory issue? Mandatory means diagnostic hallmark of the glomerular disease. It is the red cell cast. You know the cast in the urine analysis. Red cell cast. Okay. With this few word, doctor, I am just coming to show you one patient. May I request someone to read it? Who will read, doctor? Anyone? Sorry, doctor, we cannot watch the time. I am reading for you. 18-year-old student presents to the student health service with frank hematuria that began some 48 hours after an upper respiratory tract infection. Patient is pyrexial, blood pressure 110/70, pulse 70, chest clear. Now patient does not have, that means the chest problem, only upper respiratory symptom, abdomen soft, non-tender. Investigation showing some abnormalities. I think you identify the abnormalities, and I am also showing, doctor, because time is maybe short. So we got the clue that frank hematuria patient having he developed the hematuria 48 hours after initiation of the respiratory tract infection. So infection usually may be the viral, and usually viral disease stay 5, 6 days or 7 days. But hematuria developed in the second day. That means after 48 hours. This is the clue. Now, what may be underlying diagnosis? Then you can give the answer. Otherwise, you cannot give. What will the possible underlying diagnosis? Hematuria is there. There is no proteinuria.
Post-streptococcus glomerulonephritis.
Post-streptococcal. Okay, any other option by anyone? No one saying anything, only listening. Huh? It's up to you, doctor. If you can interact, I told you, you can learn more. Post-streptococcal will be few days later of the disease is over. Suppose upper respiratory tract disease finished, then 1 week after, usually 1 week after, maybe after 2 weeks, it is post-streptococcal disease. Dr. Abdullah, please, you understood your mistake?
Yes.
During the illness, that means in the first week rather, if patient develop hematuria, more likely this is IgA nephropathy. And the most of the cases, the treatment of IgA nephropathy is observation. Patient go back to the normal state in most of the situation. Okay. Now something about the proteinuria. There are two terms: albumin creatinine ratio in the urine, protein creatinine ratio in the urine. To identify the total 24-hour urine protein measurement, this is an indirect way To see the proteinuria, there are not, Doctor. I will not detail it. Just to show you, there are two terms. ACR, albumin creatinine ratio, another is the protein creatinine ratio. The values are little different. Okay. Usually albumin creatinine ratio is measured and found, checked in the diabetic patient. But there's some other situation where proteinuria is there. In that case, we see the protein creatinine ratio. Okay. Now, which urine test to use? Dipstick test, actually. Okay, for what purpose? So, and the quality, dipstick quality, urine protein creatinine ratio quality, and urine albumin creatinine ratio qualities are explained here. Okay. For the albumin quantitation, and you see protein creatinine ratio better could be done in the myeloma patient. Myeloma. In the myeloma, better to see protein creatinine ratio, not albumin creatinine ratio. To differentiate the kidney disease, acute or chronic, this chart can guide you, doctor. This chart can guide you. But in short, 1 minute, doctor, if I say you, if CKD patient is the renal issue persisting more than 3 months, remember the months, 3 months. Like the chronic liver disease, it is a 6 month. In the CKD, it is 3 months. Abnormal observation in the kidney persisting more than 3 months, we label it as chronic kidney disease. Now, acute and the chronic differentiating points are given here from the history up to the investigations. Right. Now, come to some urine analysis report, number 1. Very simple. Your main focus will be here, chemical examination and the microscopic examination. Please look at these two areas mostly and identify. Who can say is abnormal or normal? Just say me the answer. This is abnormal or normal?
Normal.
Normal.
Is normal. More likely normal. Trace proteinuria is almost less significant. If needed, we can make a follow-up urine analysis. Trace proteinuria, otherwise normal. Okay, now number 2. What bad observation here? Anyone? What bad observation here? Patient age is 6 years, baby, must have the same.
Alkaline urine.
Alkaline urine. Alkaline maybe, doctor. Alkalinity may be normal also. Usually acidic. Why not albumin plus, doctor? You are telling?
Yes.
Albumin is positive.
Again, 1 plus albumin may not be significant. What will be our job now? Next, recheck the urine after 1 week. Because there is maybe. And there are some false positive report also. I told you, possibly I did not detail in this slide. False positive and false negative result of the protein also we have to consider. Sometimes this condition, alkalinity, possibly the albumin may be precipitated and show 1 plus albumin. So we need to consider these things. So this is abnormal and the proteinuria. Okay, now the next one. What abnormality it is shown here? Please, anyone?
Hematuria.
Very right, hematuria. No other problem. No other problem other than hematuria?
Yes.
There may be
Again,
pus cell,
albumin slightly raised.
albumin slide plus albumin and pus cell a little high up, maybe more than 5 significant if there is a symptom. But it is said that if plenty RBC is there, because RBC will be broken, pure RBC, it may show some albuminuria or proteinuria. So it may not be significant, but it may be proteinuria as well as hematuria may be features of what? Glomerular disease. Glomerulonephritis could be there. It is also true. So we are now looking at the report only, but we need to look at the patient.
Yeah.
So this is a gross finding, plenty RBC and the proteinuria. Okay. Now sampling of the urine. For what purpose? What sample is important? Usually we ignore it. We write only urine analysis in the prescription. We are actually, it's a lab person's responsibility more or less. They will guide the patient for this advice. What advice? The routine screening, chemical or FEME. FEME means full and microscopic examination of the urine. Traditionally, we are saying that routine analysis of the urine. routine urine analysis. For that, random specimen anytime can be given. But for pregnancy test and the microscopic test, better sample will be the morning sample. For the culture, definitely better clean catch, midstream urine. So we need to actually, suppose lab persons are doing, as a clinician, we need to be aware of such thing. There may be false positive and false negative result. You are advising the pregnancy test, the sample not taken in the morning time. Pregnancy test may be negative. So it's a gross, actually important decision making will be in problem. For that, we need to be aware of these technical informations when we advise urine analysis. Now come few talks on the liver test, doctor. Liver means liver function test. Before going there, these are the viral marker for hepatitis B. There is a window period where the HBsAg is 0, that means become undetectable, maybe after 4 months or near about 5 months. And then antibody develop a little later. So in this time, if you measure, HBsAg may be negative, and antibody also cannot be measured. So how can we say that patient have hepatitis B infection in this time? It is called the window period. Who can say? By measuring what?
Antigen.
Surface antigen.
Yes, this one. There are 3 colors are there. Color means one dotted line, one straight line, another is the green color. So which usually we advise? This dotted line. Dotted line means IgM, anti-HBC, core antigen, antibody IgM. In the window period, this is the investigation of choice to see. Otherwise, we will be in problem. Okay. And this is the chart, doctor, for evaluation of a jaundice patient. And I think, doctor, as time may not be too much in our hand, I am advising you to make a snapshot, doctor. If possible, in any other time, doctor, in our WhatsApp group or in the Telegram, if you have time, you can discuss. But I like to say that all jaundice patient is not having hepatitis. There may be underlying Gilbert syndrome. So as a GP, if I can diagnose the Gilbert syndrome, I don't need to refer the patient to the hepatologist or any specialist. So for understanding the Gilbert syndrome, we need to understand all the algorithm here. I hope that you will understand. And you have learned also before maybe of this slide. And in general, the viral disease, viral hepatitis produce enzyme level in a little higher enzyme level, liver enzyme. And in the chronic disease, chronic liver disease, enzyme level relatively lower. In acute disease, enzyme level relatively higher. This is the fact. You see that less than 100 in the chronic hepatitis C and the chronic hepatitis B. All are the causes of the chronic liver disease. So in the chronic liver disease, enzyme level usually low. In the acute disease, level is high. You see acute viral hepatitis usually more than 300. And how to compare the viral hepatocellular damage and the obstructive feature? By looking at the alkaline phosphatase. I think all of you know. And a critical evaluation between the alcoholic disease and non-alcoholic disease. Patient may have the fatty liver problem also. The patient may be drinking very less amount also. So this ratio here also helpful, doctor. AST to the ALT ratio. If AST is more than ALT, remember the word, and it is not simply more, it will be the more than 2 times. It is in favor of alcoholic liver disease. This is the important message, doctor, I like to share from here. In addition feature, you understand that the alcoholic liver disease MCV will be high. So CBC can help us to compare these informations. Right? In the fatty liver disease, MCV maybe for the dyslipidemia may be high, maybe normal. But usually in the alcoholic liver disease, MCV will be high. Okay. Now come to another patient, and may I request anyone, Dr. Rasha, doctor, if you don't mind, can you read it?
Yes.
Yeah, please,
24
please.
years old.
Yes.
24 years old gentleman has come to discuss his recent blood test result. A few months previously, he had a private health screening that liver function test done at that time show bilirubin level of 41, normal between 3 to 20,
Yeah.
with the reminder of the liver function profile being within normal limits. Today, tests show normal full blood count, renal function, and thyroid function. Repeat the liver function test reveal bilirubin 40, ALT 35, ALP alkaline phosphatase slightly raised 104, conjugated bilirubin 7. He is well in his health and has no significant past medical history. General system examination is normal. What is the likely underlying diagnosis?
So these are the message we got from here. Health screening means usually he's a healthy person, right? Health screening.
Yeah.
Only bilirubin is high. And it's still high in the repeat level. But enzyme level, normal. Okay?
Yeah.
So what is the diagnosis underlying now?
Gilbert.
That is the Gilbert. If it is the Gilbert, so
Gilbert.
cholestasis, doctor? No cholestasis, alkaline phosphatase, you see.
Isolated bilirubin high, Gilbert syndrome.
Yes, isolated bilirubin high without any symptom and investigation data. This is the Gilbert syndrome. So
mainly unconjugated, yes.
Yeah, whatever say.
But in Gilbert, it's mainly unconjugated, right?
Yes, because he gave you conjugated 7. So it is mainly unconjugated.
Another patient, doctor, who will feel better to read it for us, just to evaluate some the viral markers, hepatitis virus. Who will not mind to read it? Why don't you feel better to read? Dr. Al-Tahir, doctor, are you here, connected? Dr. Al-Tahir, please, can you read it, doctor?
Okay. 46-year-old woman with chronic hepatitis C infection returned to you because she is losing weight. On examination, she is very thin. You sent some blood sample for tests. The results are anti-hepatitis A negative, hepatitis B surface antigen negative.
So all of you look at the findings, which one negative, which one positive. By understanding this, what will be the most likely diagnosis now? Patient is already in hepatitis C infection from many days before.
Carcinoma.
Hepatocellular carcinoma.
So alpha beta protein is high. Anti-HCV high because C virus is present. This is important clue. And anti-HBs is high, doctor. What may be the reason?
Vaccination.
Vaccination. Why?
No,
Why not added B virus infection?
No, not.
Chronic.
Super infection.
Super infection. If super infection is there, there will be this red line. What is the red line? Anti-HBC, IgG. Anti-HBC, IgG. So what is anti-HBC here? It is negative. So how can you say that this is super infection or added infection? Rather, this is immunization against B virus. Clear, Dr. Abdullah?
Yeah,
immunization against the B virus means vaccination.
Yes, anti-surface.
If previous infection happened, it would be that the anti-HBC will be there, IgG. So this is the message. But now the patient developing weight loss. What may be the reason? Maybe underlying carcinoma, hepatocellular carcinoma.
High fetal protein carcinoma.
A big slide is there, doctor, but to let you know, when you advise hepatitis B vaccination, please follow up the patient with this antibody level. And it will be a decision maker. If the titer is as such, your action plan is written in the right side, doctor. Though I have collected in the Oxford Handbook of Clinical Medicine, you can make a snapshot, doctor, for your better understanding. I will not discuss more. Just look at the titer. There is some value, significance of the titer. And now, a few slides remaining, doctor. I hope we can finish within a few minutes. A very common topic. Without the diabetes, actually, a doctor cannot leave his or her chamber. Those who are especially the general practitioner. So we need to know the very basic thing of diabetes mellitus. And what I have selected for you now, a patient as such. And who will feel better? Dr. Bashir, maybe I find here, huh? Dr. Bashir. Maybe you join a little later. Dr. Bashir, are you there to read it now? Hi, Dr. Bishbish. Sorry, doctor, not able to open. No time also, let me read. 52-year-old male with a history of dyslipidemia, hypertension, attended surgery for 74-gram oral glucose tolerance. This is the test and a part of his cardiovascular risk assessment and the screening for type 2 diabetes. So patient does not have symptom again, doctor, right? Symptom is not the symptom of diabetes. Only for the screening purpose, the test is done. BMI high, 29. Pressure 135/85. Patient is on the medicine, amlodipine, perindopril. So the result is as such. So you got the result abnormal or normal. You can decide by yourself. What will be your diagnostic labeling from this file? Now answer, please. FR. Sorry, I cannot utter your name, doctor. FR. What do you think?
Impaired glucose tolerance. Because fasting is normal, yes, but postprandial glucose is less than 11.1. This shows kids it is impaired glucose tolerance.
Very right answer, doctor. Very, very right. Very, very right. So by the slide, I like to show you is what American Diabetic Association telling. But usually in our South Asian people were following the World Health Organization or the NICE guidelines from the UK. So there is some differences there, but mostly there are some same, the consensus is there. But only one thing I will explain a little later. How to diagnose the diabetes? By testing 3 sugar. One is the glycated hemoglobin, another is the fasting sugar level, another is the 2-hour postprandial after the 75-gram glucose. So there are 3 tests for the diagnosis of the diabetes. Again, there are 3 tests for diagnosis of the pre-diabetes. That means any test is positive, we can say this is pre-diabetes. So we need to remember the cutoff value here. But if the patient is symptomatic, if anyone is positive here, it is diagnostic of diabetes. Symptomatic means patient have polyuria, polydipsia, unexplained weight loss, or even the weight gain also. And any one of these 3, we can say that patient has diabetes. But if the result fall within this one range, now Dr. Effer nicely said, it will be the pre-diabetic state. And the pre-diabetic, one example is impaired glucose tolerance. Another one is the impaired fasting sugar. So impaired fasting sugar or impaired glucose tolerance, or even the hemoglobin A1C in this range, 5.7 up to 6.4%, it will be pre-diabetes. Now, the difference I am telling you, I think all of you now understood that the diagnostic value in the fasting level, you see, this American understanding is in the pre-diabetic level. In the UK, it is 6 up to 6.9 or 6.1 up to 6.9. But in American Diabetic Association, doctor, you can say this is 5.6. It should not be confused by you in future, doctor, in different literature. In American Diabetic Association, the lowermost value is little different than the UK. That means from the NICE guideline. You see, fasting plasma glucose more than 6.1 is impaired glucose. More than 6.1. But in American one, it should be 5.6 up to the level. So is a lower level also. So in American people telling that the normal blood glucose should be less than 5.6. UK people telling that normal blood glucose will be less than 6. I think things are clear to you. Things are clear to you. Even in the A1C level also, there is some difference. If you look at the book, in the A1C level, ADA means American Diabetic Association. They are telling that the lower fasting glucose, already I told you, lower fasting level should be normally less than 5.6. And in the A1C also, doctor, you see the 39 up to 47 American Diabetic Association normal range. But in the UK, they are saying 42 up to 47. So the difference is the lower limit, 42 here and here is 39. I am not sure it will be confusing for you or not, but in our lab setup, doctor, all the literature, the South Asian people, doctors, we are reading from book is UK oriented one, not American. But for your senior understanding, attending the seminar symposia in different countries, American people will tell in such manner. Now, very important thing, how to prepare our patient for the test, for the glucose. These are not usually followed, doctor, in our experience. Suppose fasting level is very easy to take the blood, but before that, we need to advise the patient, no restriction of the food as previously. When you advise the blood sugar test, maybe on that night, patient will not take the food and patient will come back, patient will come into the next morning without almost no food because he is aware, he is afraid that diabetes may be detected. We have to explain that the 3 days better not to restrict your carbohydrate food as usual. You take your carbohydrate food as usual. And the fasting overnight, 8 hours, come in the morning and patient will be 30 minutes in the rest. Doctor, do you think that in our busy lab and other, patient is waiting 30 minutes? Can share any experience? Dr. Rasha, what do you think? In the lab? They are coming very rapidly, right, doctor?
Yeah.
And paying the money and going there, moving here, there. They are very sura, doctor. Sura. Moving around. And giving the blood, where they are going, doctor? Going to the shop, in the market, and the lab, you see nearby Hyper Panda, they are going to the Hyper Panda. And coming back after how many hours? 2 hours. It's a very long time. Yes, it's a very long time. Why they waste their time? They are very busy. But for the OGTT, patient should be in the rest in the 2 hour, doctor, in the laboratory. Am I advising our patient in that manner, doctor? Mostly no. We are just writing advice, fasting sugar or OGTT, the one word. So we need to be cautious. We need to be cautious. For that, doctor, I'm just humbly sharing with you. For the diagnosis of diabetes in my patient, I don't advise this postprandial 75 gram glucose drink sugar. But I advise fasting sugar and hemoglobin A1C. So patient does not need to come back after 2 hours. As a diabetic patient, I need to follow the A1C also for future treatment monitoring. So it is better for me. But in some situation, critical situation, diagnostic purpose, where there will be confusion, after glucose drink may be advised. But in general, doctor, if you agree with me, you can follow fasting sugar with hemoglobin A1C. So this is the diabetes, doctor, very critically, and you understand that as a doctor, as a GP, unfortunately, we don't follow these. So our diagnostic labeling will be with error, doctor. Will be with error. And now
doctor,
in the back,
one
please.
reading,
sorry.
One reading hemoglobin A1C significant, maybe 6.5. I will set David. Yes.
No. It is doctor. No. The diagnostic level is a different, doctor. 6.4. Yeah. Sorry.
More than
5. Yes, 5 or more than 5. But there are some other unit, doctor. Sorry, this is other unit in the what unit?
Normal hemoglobin.
No. I'm telling you, we need to remember in nowadays millimole per millimole. This is also nowadays practiced. Millimole per millimole, not in percentage.
Hemoglobin A1C.
A1C, yeah, millimole per millimole. So 42 up to 47. There is a difference of 5. 42 up to 47, difference of 5. Difference of 5.
Oh.
Okay. Now the pregnant lady is a little different values of diagnosis. Gestational diabetes, usually done in the 24 to 28, maybe around 7 to 8 months around. Not 8 months, 6 months or 7 months time. 24 to 28 weeks within this time. And in this time, you see, doctor, we need to get the 3 sample blood, not 2 sample. This is also OGTT by giving 75 gram glucose, 3 sample. There are some different 100 gram glucose doing also options are there, but very simplified. We need to go as a routine test, But for the high risk patient, we need to check earlier in the pregnancy earlier. And the cutoff value also a little different. Doctor, have a look. It is not the same. So average risk, high risk, and the no risk means no test. But if you go through the risk factor, doctor, especially South Asian people and the Middle Eastern colleagues today, a lot of you are here. So everybody is in the risk of diabetes. Everybody, as we are from South Asia and the Middle East, South Asian other, and the BMI is high. So everybody in the world practically should, those are the pregnant, should be tested for the sugar. So GDM usually in the 24 to 28 weeks. But nowadays, by definition, the high blood sugar detected first time in the pregnancy, maybe in the first month, it is also pregnancy-related diabetes to give more importance. But traditionally, the GDM defined in 24 to 28 weeks gestation. So this is significance for the future as well, doctor. This is GDM and the thyroid. I'm sorry, doctor, if I hold you for a few minutes more. Better to finish also. It's a freedom of you also. If you can have important time, you can be away also. I will be with you a few minutes more because I have planned to finish some other thing important. We are advising, and as I was mentoring many GP program and the OSCE program also, these important investigations are very important. So the thyroid function test will be the first line test to evaluate the thyroid disease first. So now I'm showing you 1, 2, 3, 4, 5, 6 example here by looking this. Can anybody say me the findings, result, what will be the diagnosis biochemically here? One by one, doctor, anyone. The number 1, what will be the diagnosis here? Most likely T3, TSH, you see, undetectable, T4 high, T3 also high. Very easy diagnosis.
So hyperthyroidism.
Hyperthyroidism, right. Come to the second one, doctor. Skip this one. Now 2. The T4 normal, T3 normal then. But TSH is low. And one means usually upper part of the reference range. 1 means upper part of the reference.
So it's subclinical or no?
Yes.
Clinical hyperthyroidism.
Subclinical hyperthyroidism. But thing will be that biochemically, how can we say that subclinical? If patient does not have any symptom. If patient does not have any symptom, then we can say subclinical. Only by the biochemistry, without any symptom, we can say subclinical. Thank you, doctor. Now come to that. The TSH is normal. Okay, don't go for the normal, rather come to the mildly elevated 5 up to 20 level. TSH 5 up to 20. It is called the mild elevation up to 20 level, TSH. And T433, both are low. What is the diagnosis?
Hypothyroidism.
Usually it should be hypothyroidism. And if it is elevated more than 20, both are low.
Severe hypothyroidism.
Severe hypothyroidism. Intelligent answer, doctor. So you may, I will show you, I will open the box a little later. There may be something different. Sometime without sorry, doctor, without hypothyroidism also clinically significant, the TSH may be higher. Whenever we say the primary hypothyroidism, usually TSH will be more than 20. This is the fact. Primary hypothyroidism, more than 20. But if both are low, It is not more than 20. It may be pituitary failure. Pituitary failure means it may be secondary hypothyroidism. But in the pituitary failure, TSH may be even above the normal level. Clear? I will show you later. So those we know about the primary hypothyroidism, commonly this one, number 4 here. Number four value, the result. Okay. And now mildly elevated, but normal T3, T4. What will be the diagnosis?
So he was right, and then he took the medication, maybe.
Oh, suppose patient is not taking medication other than this. You are telling again the subclinical? Subclinical something?
Subclinical hyper.
But they are giving the explanation. Number 2 means T3 is not sensitive indicator of hypothyroidism. Should not be requested. Okay. And the 3 means usually lower part of the reference range. T4 is the lower part of the reference range.
Subclinical, yeah. If no symptom.
Hypo.
Subclinical. So subclinical hypo means TSH will be high. TSH will be high. Now come to the 6th one. Elevated TSH. So elevated TSH means we expect that T4 will be low, T3 will be low, but both are high.
So this is the one who's dosing it before test, I think.
You know it well because people are doing technically mistake. Patient took the thyroxine maybe 1 day before of the test.
Yes.
Yeah.
So this is the result, doctor. You can see in the book also. Non-compliant patient, T4 replacement. It may be secondary thyrotoxicosis, pituitary gland secreting more TSH. So thyroid gland also secreting more T3, T4. It may be another explanation. But commonly, common disease, common thing, not disease, this is the patient mistake. Patient is getting T4 before the test. And here we are discussing elevated, mildly elevated, but normal T3, T4, subclinical hypothyroidism. Your answer was very, very right. Very, very right. And that was elevated 5 up to 20, but T3, T4 low, primary hypothyroidism. Primary hypothyroidism, but it may be secondary hypothyroidism also. So this result may be confusing. So in summary, doctor, to be confident about our hypothyroidism, what will be the TSH level? More than 20. More than 20. So other endocrine means, just to show you one picture, hyperprolactinemia may be due to many, many reasons. Not only the pituitary tumor. You see, pregnancy, lactation, even the stress people also have high prolactin. One important other endocrine disease, primary hypothyroidism, can produce hyperprolactinemia. So these are the tumor and different values are suggestive for different diseases. Usually macroprolactinoma, huge amount of prolactin will be there. Pregnancy, one of the physiologic cause of hyperprolactinemia. What I actually attached this slide, I remember that in my Gulf country job also, even in South Asian people, for some personal life issue, they are checking the hormones, testosterone, prolactin, but unfortunately, they cannot explain it also. Why this is high? And high prolactin, we are giving prolactin lowering drug. It should be justified in presence of this situation or not. What did I have shown to you? And in the investigation of the endocrinology, we need to know that endocrine, that means hormones, are very much vulnerable on the different time of the day and different situation. Different situation means I show you after prolactin may be high. You see, even in the stress situation, prolactin will be high. Even in the irritation of the nipple also can produce hyperprolactinemia. So many physiologic conditions can cause abnormal blood at the level of the hormones. For that, usually we don't go for the testing cortisol level in the random fashion. Okay, many hormones we have to go for dynamic test, stimulatory test or inhibitory test. Only thyroid hormone usually we do for as a random fashion. Otherwise, almost all other hormones we check by measuring the random in the dynamic fashion, stimulatory or inhibitory test. And after biochemical test, if we confident that disease may be in the pituitary or outside pituitary, then I will advise for the imaging study, MRI or CT scan. So biochemical test is first, then we will advise for imaging test to identify to the location of the disease. Okay. And only one picture to you remaining, I know, doctor. This is the ASO titer. Sorry, doctor, maybe 2 slides. Sorry, 2 slides remaining. Regarding the ASO titer, 4-fold rise is important. If we can do after 2 or 3 or 4 weeks later, then we can say significant ASO titer. Why I am showing this? Acute rheumatic disease or the rheumatic heart disease, whatever we said, that means the rheumatic fever, wrongly diagnosed only by looking at the ASO titer. Patient may have some pain, joint pain, muscle pain. Patient does not have typical arthritis, but only looking at the ASO titer. So this is the data, doctor, for you. Don't be confused or biased by ASO titer. ASO titer usually is the features of the streptococcal infection. It is not the features of the heart disease, that means the rheumatic fever. If added other diagnostic features are there, then we can say this is rheumatic fever. And single ASO titer in the children may be significant if 5 to 15 years of age, but a little advanced age, the rising titer will be significant, rising titer. Otherwise, we cannot say the ASO titer is bad. And this is very extraordinary investigation, very specialized investigation, as I had collection for one of my patients. Just to show you, maybe complicated to you, the test of what? What is the name of the test? Sample is the blood, the RT-PCR to detect, you see, BCR abulsion gene. BCR abulsion gene. What is the indication, doctor? In which disease we do it? Anybody can say? BCR abulsion gene test. Chronic myeloid leukemia. That means the leukemia patient, we go for this. So this is that critical test result may be in front of you, doctor. If you don't understand, Dr. Rasha, what you will do? Suppose you don't understand.
I don't know.
You will say, I'm sorry, I will let you know later. I will talk to my senior, then I will explain later, right?
For the patient, yes.
That will be the idea. Maybe because our patient doesn't know that I am a GP. All are doctor to them. So they can give me very complicated investigation also. Actually, what I cannot explain to the patient, it may happen. So again, thanking you and showing my gratitude. I like to finish my session now. Thank you very much.